Good afternoon, ladies and gentlemen, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press star 0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator, Ms. Jennifer Major, Senior Improvement Lead at the Canadian Foundation for Healthcare Improvement. Please go ahead, Ms. Major.
Thank you, and welcome to everybody on the line today. So today is the second in our Transforming Care for the Elderly 3-part series, and we'll focus on how to engage pharmacists and interdisciplinary care teams to improve prescribing of antipsychotics and to reduce inappropriate antipsychotic medications. So I'm Jennifer Major, and I'm pleased to be your host today. So we actually have more than 170 registrants for this session, so welcome again to everybody. We invite you as we go along to ask questions through the chat, and for the duration of the webinar, we do have a formal question and answer period at the end of the webinars once all the presenters are finished, but we'll also address questions as we go on, and I see already Susan McCauley has asked a question to Krista. So Krista, kindly you can answer that through the chat, and we'll discuss it further at one of our question and answer periods. So as I introduce the guest speakers very shortly, I'll ask that you also take a moment to introduce yourselves in the chat box. So I see that some people have started to do that, so we encourage others to do so as well. We know that we have callers from across Canada today. And we also ask that you let us know how many people are attending with you from your location using the poll on your screen. So enter the number, including for yourself. So with us today are Alistair Bursey, who's the chair of the Canadian Pharmacy Association Board of Directors for the 2016-2017 term. Alistair is a graduate of Dalhousie University and is currently a pharmacist owner in Fredericton of the John Couteau Pharmacy. Krista Millet-Rochon is a certified geriatric pharmacist and a certified diabetes educator. Krista received her Bachelor of Pharmacy degree from the University of Laval in 2007 and currently focuses on long-term care residents through her employment at John Couteau Pharmacy in Fredericton. So Krista and Alistair are actually colleagues, so welcome to you too. We also have Dr. Paula Rochon with us. Dr. Rochon is a geriatrician and the Vice President of Research at the Women's College Hospital, which is fully affiliated with the University of Toronto. She's a senior scientist at the Women's College Research Institute, a professor in the Department of Medicine and Institute of Health Policy Management and Evaluation at the University of Toronto, and a senior scientist at the Institute for Clinical Evaluative Sciences. We also have with us, behind the scenes, Sheena Powell and Kelly Ripley, who are operating and the producers for today's call. So a warm welcome again to all of you. We're pleased on today's call to also provide simultaneous interpretation. So this will result in a few quick pauses in the dialogue here and there. We do invite you to participate in our chat box in either French or English, and we will provide translations as we go. So the objectives for today's webinar, at the end of today's webinar, we hope that you understand a little more about CFHI's appropriate use of antipsychotic intervention, which we've supported organizations to tailor through 2 collaboratives that CFHI has led, the Pan-Canadian Collaborative and our current New Brunswick Appropriate Use of Antipsychotic Collaborative. We also would like for you to be able to identify strategies that you can use in your own organizations to improve pharmacists and interdisciplinary team engagement in your healthcare improvement initiatives. We hope that you'll be able to describe typical prescribing cascades and the implications they may have for medication reviews and how you might work together with your pharmacists. And we're also going to tell you about an innovative pharmacy practice model that's happening in Fredericton and how those innovative models can also improve prescribing and care outcomes in the elderly. So before I turn the call over to our presenters today, I want to provide just some brief background on the bilingual collaboratives that CFHI has led to support long-term care homes across Canada to improve appropriate use of antipsychotics. So on the map of Canada on this slide, you see the names of 15 organizations that CFHI worked with in 2014 and 2015. So in participation of this collaborative, each organization pictured here, so it's 15 long-term care organizations, which includes 56 long-term care homes, received seed funding and education required for nursing home staff to tailor, implement, and evaluate an intervention that had demonstrated success in improving antipsychotic use in the Winnipeg Regional Health Authority. So the collaborative was delivered via a series of monthly webinars, open coaching calls, and online support forums and teleconferences. We also hosted many in-person education sessions. On this slide, we see a map of New Brunswick. So since May of 2016, we've had 15 long-term care organizations in the province of New Brunswick work with us in a very similar collaborative up to the Pan-Canadian Collaborative. So similarly, each organization is receiving seed funding and education for them to be able to tailor, implement, and evaluate an intervention to improve antipsychotic use. So the delivery method is very similar, whereby the education is mostly provided through webinar, but we've also added a lot of additional site visits and in-person training sessions made possible through our partnership with the New Brunswick Association of Nursing Homes and the provincial government. So the rest of the nursing homes in New Brunswick are actually joining the collaborative, with their first webinar happening actually next week. So we'll have 66 long-term care homes in New Brunswick that we're working with. So the objectives of this collaborative are to reduce inappropriate use of antipsychotics in nursing homes, improve quality and experience of dementia care for nursing home residents, families, and staff, and also to importantly build individual and organizational capacity in designing, implementing, evaluating, sustaining, and spreading resident-centered and data-driven dementia care innovations. So what exactly is the intervention that we are putting forth and providing training around through these collaboratives? Well, the core components of the intervention that we train these nursing homes to implement and evaluate is indicated on this slide here. So there's first and foremost education to all staff to increase skill and to devise and deliver person-centered approaches to care. So that's about, for example, being able to identify why a resident is acting aggressively, and then to be able to work with the core team to devise strategies to be able to offset those behaviors. There's also multidisciplinary teamwork and communication between families, leadership, physicians, pharmacists, and all other frontline staff. So we'll talk more specifically about the role of the pharmacist today, but for example, when we work with the families, we want to get things like the resident personal family, their history, so we want to know what hobbies that resident had, because that's going to inform some of the strategies that are delivered to offset, for example, aggressive behaviors. There's also regular medication reviews. So we teach all of our nursing homes that it's at least quarterly medication reviews with your homes, but more frequently during reduction periods when you're really focusing on a resident or two to reduce medications that are inappropriately prescribed. We also teach and provide support around to our homes to be able to allow them to do ongoing data collection and analysis to be able to, in real time, inform care planning. And there's also a strong component of our collaborative around the de-prescribing guidelines. So we know that there's safe ways to reduce slowly medications in residents. So that's, again, another example of how a pharmacist is really involved on the care team to be able to support the organizations and long-term care homes to improve prescribing in their residents. So I had mentioned that this is the intervention that we support homes to implement in their homes, and so the actual implementation of the intervention is done by a core project team, and this project team, the names is listed here on this slide. So an important team member is a project lead who makes sure that there's milestones set and that there's meetings with the multidisciplinary teams where required, and then there's, for example, the pharmacist who plays the role of the medication review. We also make sure there's someone who's there to evaluate and track performance of the collaborative. So I can answer more questions about the team composition if people are interested. So I've mentioned how the collaborative actually operates, which is mostly through online learning such as webinars, and we provide coaching and also opportunities for cross-team sharing. So we have a few in-person workshops, for example, where all the nursing homes come together and are really able to share their successes and talk about how they can all improve and share with one another. So what are the results of the collaborative? So I will talk today, right on this slide, we see the results of the pan-Canadian appropriate use of antipsychotic collaborative, because that's the one that's complete. That was between 2014 and 2015. So over the course of less than 1 year, those 15 nursing homes and the 56 long-term care organizations achieved these really good results. So they showed a 54% elimination or reduction in inappropriate antipsychotic prescriptions. 36% of this was total elimination of medications, and 18% was reductions. Coupled with that, there was no increase in aggressive behaviors and actually reductions in falls, the incidence of falls, verbal abuse, for example. And what you don't see here on this slide are the resident and family stories of improvement, where we know that residents became more active and able to independently perform activities of daily living, like feeding themselves, and became more verbal with their family members and the care staff. We're also achieving similar results in the New Brunswick appropriate use of collaborative, which I'd mentioned previously. Right now we're working with 15 homes in New Brunswick. So on the third of this webinar series in February, please stay tuned and we'll give some more examples and snapshots of the results our New Brunswick homes are seeing. So one of the central objectives of today's call, as I've said, is to talk about pharmacist engagement. So to specifically hear about some of the strategies that you may be able to use in your organizations to involve pharmacists in quality improvement initiatives. Well, through our Pan-Canadian Collaborative and the NBAUA Collaborative that I just mentioned, all these organizations are engaging pharmacists as core members of their improvement teams to help achieve those great results I just discussed. So at York Care Center, this is a 214-bed home in Fredericton, New Brunswick. They achieved really great results through our Pan-Canadian Collaborative. Over the course of just 1 year or less than a year, York Care Center was able to successfully reduce inappropriate prescribing in their residents by 89%. And Krista, who's on the call today, and I'm going to turn it over to shortly, was the lead pharmacist at the York Care Center who helped to achieve these great results. So we'll hear from Krista next about what strategies she used and how she was engaged as a pharmacist in this improvement team, and she'll provide you also with some tips and suggestions for how to promote engagement and quality improvement with your pharmacists and your organizations. So before I'd ask, I'll turn it over to Krista just momentarily, but I do encourage everybody to, in the chat feature, tell us about how you've engaged pharmacists in initiatives to improve prescribing or in other quality improvement initiatives. And then when we get to our question and answer period, or perhaps after Krista's finished her presentation, she can comment on some of the responses that are made in the chat box. So Krista, over to you.
Thank you, Jen. Hi, everyone. I'm very happy to be here today. I'm going to talk to you a little bit about, like Jen said, our experience that we had at York Care Center with the reduction of the antipsychotic initiative, and how we were able and how the whole center was able to engage the pharmacists in that initiative. So I just want to first off talk to you a little bit about what role the pharmacists actually had on this team. So we called it a quality improvement team, and that team included the physicians, the nurses, there were some care aides, there could be people from recreation. It can include a whole lot of different of people on there. And so myself as a pharmacist, I would participate in all the medication reviews to potentially identify candidates that would be good candidates for a reduction in their antipsychotics, and that was all done with the RN on staff. I also help the nurses to devise some titration schedules and different appropriate therapies. So how to reduce those antipsychotics appropriately, and if we needed something else to control behavior, what were the other options that would be better than antipsychotics. The pharmacist should be, available to that team at all, at all times, and should be there to advise not just nursing staff, but the physicians also about what are alternatives. So of course we like to push patient-centered care as the first alternative, but if that doesn't seem to work, then what would be some other pharmaceutical options for the residents? The pharmacist can also become the champion to the staff and also to families, and so they're there to communicate, the importance of why we should be reducing antipsychotic medications, what are the risks associated with it, and just to reassure families that we're doing this to improve the quality of life and to minimize medication waste, because some people are getting the antipsychotics and they're not doing anything. So we're basically giving them medications and for nothing. Also, the pharmacist can help engage and communicate with physicians and the families as well, like I said earlier, and lead some of the education sessions. So like we did at your care center, there was quite a few sessions on antipsychotics for staff. What are they, why are they bad, why are we reducing them, and what type of titration schedule are we doing, and why it's important to find that lowest effective dose. So pharmacists as partners, here are some of the best practices. We, as pharmacists, we're always taught in school to use best practice guidelines. So we like to incorporate some evidence-based principles in everything that we're doing. And when we're talking about antipsychotics, we're not talking about evidence-based medication in terms of dementia, because we don't have any studies that show any effectiveness for the behavioral problems related to dementia. And we always try to be evidence-based in our recommendations. Also the pharmacist's contribution should align with their scope of practice or expertise. So you'd like to have a pharmacist that's interested, obviously, in this area, and that wants to further their education and expertise on it. And you want to include the pharmacist in all those reviews. So the resident reviews, if you have interdisciplinary meetings or multi-disc meetings, or any type of meeting or staff meeting that the pharmacist could help. So the pharmacists, they are the the experts in pharmacotherapy. So you really should be taking advantage of them when you're talking about medications. So I just have a couple other slides on how to promote the engagement of pharmacists within that quality improvement team. So here are some tips for some of the managers of those teams. So you want to make sure that you have a regular meeting, or sometimes we like to call them huddles with your team. And they could be just very informal, just 5-10 minutes. Little huddle just to speak about the residents that we're starting reductions on, how are things going, what can we do different. The pharmacist can be there, to act as a liaison between, everyone, and can be there to intervene if needed. So there's we want to avoid issues, within nursing staff and physicians. There have been, issues in the past with sometimes some nurses being maybe intimidated by physicians. So the pharmacist can be there to kind of just reiterate why we're doing the project and why it's important, because we always want to try to reduce quality or improve quality of life with these residents. So we want to participate also in, like I said before, education and also our celebratory events. So it's really important if we are reducing the medications in someone, that we celebrate those successes and that we let everyone know about it. Just to be present during rounds, and also to work with the doctors to just build those relationships, and encourage them. And again, just reinforce that message that we do want the positive outcome for the residents. And just this very last slide here for me about communications. So we always want to be very clear with physicians about what's going on. So when we're talking about potential problems in behavior, we want to have ready a current list of medications. We want to know if there's any side effects that were noted from the antipsychotics. How long has the antipsychotic been used? Was there any recent dose changes, any reactions? We want to use the MDS outcome indicators if we have them, and also, the behaviors and potential causes for the behaviors. So behavior tracking or behavior mapping becomes really important here, and what we have been telling our physicians at your care center is that they should almost always be asking for behavior mapping when they're being called about a potential behavior problem. So nurses try to do behavior mapping for a good week before they even call the doctor, and because we want to make sure that we're using those non-pharmacological treatments before we jump into the medications. So definitely you can see that pharmacists have a very important role in this, with everyone involved, from, like I said, the physicians to the families, and directly to the residents. So if you have access to a pharmacist, which I'm sure you all do, definitely use their expertise here to help you out. So I will pass this on now to Dr. Paula Rochon, and to talk about prescribing cascades.
Thank you very much. Can you hear me? Good.
Yes, we can hear you.
So I think my presentation follows very nicely from the one that we just heard, and there'll be some nice links between it. So what I'm going to talk about is the concept called prescribing cascades, and how that can be helpful to you in your medication review process, and help, I think, really facilitate the ability of the prescriber and the pharmacist to really work together with making a difference to prescribing. So if we go to the next slide, I'm going to start with a case, because I think it's important to put a sort of a face and a story behind what some of these issues might look like. So this is a story of a lady, Mrs. X, who's in a long-term care home, and she was diagnosed with dementia. Now, I know that you've heard this scenario many times, but she started on a typical antipsychotic for the management of the behavioral problems that have been associated with her dementia. So I think if I was to ask this audience, would there be concerns about that in particular, I know you would probably identify a number of different things that would come to mind. For example, what was the behavioral problem that was being experienced, and what were the other strategies that had been put in place before this decision had been made. And so I'm sure there'd be many things that would be asked. But anyway, this is a woman who was started on an antipsychotic therapy. So let's go to the next piece. And over a period of time, and it was over weeks to months, it was noted by the staff that this woman was a little bit different than she had been in the past. So they felt that she was just a little bit slower than they'd noticed previously, wasn't walking quite as well, a little bit more sort of shuffling in her gait, and they just didn't really know what to make of that. So again, I would ask you, what's coming to mind when you're seeing something like that, and what are you thinking? So what did happen to this individual is that her physician went on to prescribe an anti-Parkinson therapy because the physician thought that this individual was developing Parkinsonism or Parkinson's disease, and therefore felt that this was something that needed to be treated. So the question I have for you is this something that's a problem? And is this something that you have any concerns about? So I'll let you think about that. And this leads in to the concept that I want to talk about today, because I do think that it is a problem, what we've seen here, when you have a person first off started on an antipsychotic, and I guess the many questions of why that's happening in the first place at all. There could have been many other options which you're well aware of that we could have followed. But following the development or the start of that drug, there's something else that's happened to that person. So this relates to a concept that we developed quite a number of years ago called the prescribing cascade. And I did it with a colleague of mine, Jerry Gurwitz, and it came out of situations just like I've described to you here that we actually saw in clinical practice. And we saw scenarios in clinical practice where people were being started on atypical antipsychotics and were developing signs that looked like Parkinsonism, and did see people who were subsequently being treated for that condition. So we published that initially in the Lancet, and later it was published in the BMJ. And since that time, it's something that's a concept that has become fairly well recognized. So let's look at a picture or a description of what it is. So a prescribing cascade starts when an adverse drug reaction is really incorrectly interpreted as being a new medical condition. So I think it's really important to look at some of the wording here. This isn't something that's necessarily anticipated and therefore you're being proactive about, but it's something that is not being recognized as being related to the drug therapy, and I think that's really important to distinguish. So when we first came up with this concept, we had examples of what these issues were. And of note, the initial publication goes back to the 1990s, and the same issues we're talking about today were issues then. So one initial prescribing cascade was just like what we just saw in that case, that an antipsychotic therapy led to extrapyramidal type symptoms or signs of something like Parkinsonism, and the subsequent initiation of a drug to treat that, so anti-Parkinson therapy. Now the other ones we've described, just so you get a sense of how these things work, is we looked at non-steroidal anti-inflammatory drugs, drugs like Advil and things like that, leading to elevation in blood pressure and the initiation of antihypertensive therapy. And another one we looked at were anticholinergics that can interfere with gut motility and lead to problems like constipation that then end up requiring laxative use. So you can see a pattern here. It's where something is started, there's something that's not being recognized as being drug-related, and another therapy is initiated. So they're important because they're adverse drug events which get unnoticed, and I think they're so important in the context of our conversation today because they're things that really can be prevented. So here's how they happen. The initial drug therapy, the new medical condition, and then you go on to a new drug therapy. So the question is, why is it that people are missing these? So, for example, some of these conditions that we're looking at that are developing related to the drugs can be, or could thought to be, things that may be associated with age-related changes. So things like Parkinsonism, people might expect that that's something that you might see in an older person, so they might not question it. Likewise, if the side effect had been incontinence, that might be something that also might not be recognized as being drug-related. The other piece that's really, really important is the temporal relationship, that these side effects don't happen immediately. It's not like you give a drug, a person develops a rash, you recognize that it's drug-related. They happen over time. Often it's weeks, usually more like months, and so they don't get linked to the drug therapy. And in fact, they may lead to a referral to a different physician who doesn't have the context and then may miss that altogether. So there's about 30-odd different prescribing cascades that have been identified in the literature. A number of them relate to classes of drugs like antipsychotics. So when I say antipsychotics, as you know, there's many different antipsychotics that are out there. And again, when you look at Parkinsonism medication and treatment, there's a number of different Parkinson medications out there. So a single class in this context can actually apply to many different individual drug therapies. So it's important to think about them because they actually become something that's much more common than you might anticipate. So how does this relate to how we use this information to improve our ability to prescribe? So I think this can help us with that process that we're thinking about in terms of really thinking about deprescribing. So part of that process is really to look at all of the drugs that the person is taking and to think about the reason for each of the drugs. And in the case of our individual we looked at here, I think that starts by they're on an antipsychotic. What is the reason for that drug? Is it really indicated at all? And you also would then consider the risk of harm, and clearly we are all very concerned about the use of antipsychotics and the potential harm, especially when there's other opportunities or other alternatives. So then the next step in the deprescribing process that's been outlined is you look at what potentially are the drugs that could be discontinued. And one of the factors to look at is, are these drugs that are potentially part of prescribing cascades? Because that tells you not only that there might be one drug that could be discontinued, but there actually might be two that may no longer be required in the same way. And when we say discontinued, it doesn't necessarily mean that the drug is always discontinued. In some cases it might be, but it's an opportunity to potentially think about reducing the dose or slowly tapering it, or thinking about a substitute in some cases. And then, as we said, in some cases it may not be required at all. It could be substituted with a safer alternative. This is clearly a process that you want to do in combination or in consultation with the pharmacist, as we just heard in our prior presentation. So some overall global messages that we need to think about in terms of preventing prescribing cascades. One of them is to periodically review existing medications when we're looking at our older clients in this context. And so that is where looking at the antipsychotic use really is important to figure out why they're on that. And there's a regular medication review process that's in place where this can be implemented in addition to the other initiatives that are ongoing. And then there's the opportunity to certainly identify meds and think about, can they be discontinued when there's no ongoing need? And as I've talked about today, the takeaway message for you all is to consider any adverse drug effect as something that could be caused by a medication. So any new symptom that you see, something that's different, one of the first things you should ask is, could this in fact be caused by the medication? And one of the medications, of course, we're concerned about is the antipsychotics. And then you do want to consider non-pharmacologic approaches, as you've been discussing in detail, especially for the antipsychotics, as your first line of approaches that you should follow, you also want to consider the opportunity of reducing the dose or potentially thinking about other medications if something is potentially indicated. So with that, that ends my part in describing the prescribing cascade, and I'll leave you with thinking about how that might be applied to the initiative in place to reduce the use of antipsychotic therapy. Thank you.
Thanks, Paula. This is Jen, and up next we're going to have Alistair, but I just wanted to ask one question before we went to do that. So the information that we've heard so far, I mean, super interesting and really good, advice in terms of how to work with pharmacists to reduce antipsychotic medications. But what I'm wondering is, it seems like a lot of work for a pharmacist to actually do this with the core team. It seems like a lot of work for the team. And so I'm just wondering, from your perspective, Paula, and maybe Alistair, Krista, you could weigh in on this as well through the chat, but what monetary incentives are there for that really encourage and incentivize the pharmacist to actually do this work with the interdisciplinary team? Like, I'm just curious about your reflections on how it's incentivized. Paula, do you have any reflections on that?
Yeah. So I'll start off, and I'm sure other people have comments as well. So I guess one of to me, the big incentive would be that we know that inappropriate use or potentially inappropriate use of medications can lead to important serious adverse events. They can lead to things like falls, they can lead to fractures, and even more serious events. So I think the cost of not doing something is certainly far greater than the time investment in this. So I don't think it's a money thing to me. I think it's just something that's so important. But that aside, there is in long-term care organizations, certainly in Ontario, a medication review process within the home environment that's done on a regular basis. So that's part of your regular practice that can be taken advantage of. And in the community, there's also the opportunities to do medication reviews with your pharmacist that are reimbursed separately. So I think there are mechanisms to do it, but over and above that, I just think it's something that's so important, and the cost of not doing something is just far too important to not consider.
Thanks, Paula. And yeah, I certainly agree with you and know that people from our collaborative homes, they definitely share those same sentiments. Alistair, I don't know if you have any additional comments to make to that, but otherwise we'll hand it over to you now to talk about how your pharmacy practice model can really go about improving prescribing and care outcomes in the elderly. Over to you, Alistair.
Thank you. And I think, when it comes down to having the right funding there for pharmacists to be able to do that impact, I think that's primarily in the provinces. There's some provinces like Alberta that are really setting the bar, and I think certainly from our national body, we are pushing really hard to have that funding in place so that patients can reach their outcomes and reduce downstream costs. So today I'm going to be speaking about how innovative pharmacy practice models can improve prescribing and health outcomes. And so the idea here is, obviously Krista and Dr. Wokan talked about leveraging pharmacists or identifying, cascades and whatnot. And I think that pharmacists are certainly excited about being able to do more to embrace a larger practice. And, when you think about your pharmacists, they're a key community partner. There are pharmacies in, I would say, probably 99% of the communities in Canada. They are the drug therapy expert. And, the nice thing about that is that they're on the front lines. They love collaborating with physicians and other prescribers, and they're a great ally for this. But one of the challenges over time, especially in the, lately in the past 5 to 7 years, is that we are having a very large proportion of the population who are entering the senior age. I think today in New Brunswick we have a stat that 19.56% of the population of New Brunswick are seniors. That's 1 in 5. And we are seeing a very large increase in the number of prescriptions and the questions and the concerns that patients have. So pharmacists over time have needed to embrace change, and I would say back about a decade ago, we started laying the seeds for change and starting to undergo practice changes and changing how we do things to utilize our skill set so that we're not necessarily doing the technical filling of prescriptions, but we're more focused on the actual cognitive side that Krista's alluding to. So if we can go to the next slide. Thank you. So I'm a visual guy, and I really like to use visuals. So on the picture on the left is probably the old school traditional pharmacy where you can see your patient counseling. Looks like I wouldn't say it's exactly ideal. And unfortunately, we have had, and we do still have pharmacies like that. And what we've done since probably around 2013, it's really been kind of hitting the front lines, is that pharmacists are being able to go to the front lines. As you can see, there are pharmacies on the right, and you can see that we have semi-private counseling areas. We also have full counseling, private assessment rooms. And the idea is to free the pharmacist from the technical duties, what I would say the technical filling of prescriptions, and focus on the cognitive side. So that would be, for example, reducing antipsychotics. And we've embraced that at our pharmacy and our practice, and we're seeing this across the country. And what it's allowed us to do is really free up the pharmacists to go out in the communities, work with key partners, such as long-term care facilities, and actually visit patients at home. And part of this transition was also that we've introduced certified technicians. So it's a new class of technicians that do a lot of the technical checks. So that'd be the right drug, right quantity, right physician, et cetera. Kind of similar to how dental hygienists came in and helped having dentists being able to focus on what they primarily were educated on in school. So that partnership has really freed us up so that we can start doing more. And we're very excited for this because we're seeing this practice change going on throughout the country. And this has certainly been one of the things that has enabled us to collaborate, with this, for example, this presentation, collaborate with Transforming Care here at York Care Center, and really start to establish partnerships. So if we go to the next slide, this is an example of what, how we can free up the pharmacist. So if you look at the diagram on the left, I tried to get a schematic. I'm not going to go into too much detail of that, but in the bottom left-hand corner of that picture, you can see that that's a private, semi-private area where we do see patients, we do consultations. And the idea here is that we're not simply counseling on the medication. We're able to start doing comprehensive medication reviews, medication reconciliation, and we can really focus on advancing the profession, but also improving the outcomes, drastically improving the outcomes of our patients. And so, you can see there, Krista's sitting there with the patient, and being able to sit down and take that time to be able to speak to the patients, which is making a huge difference in our practice. So if we move on to the next slide, what that enables us, and this is something we're big on, and this is changing over time, is that we're able to identify drug therapy problems, so such as inappropriate prescribing of antipsychotics, or in some cases we see benzodiazepines not being prescribed, but no anti-anxiety medication to help with the underlying condition. So what we've developed and we use is a healthcare practitioner communication forum where we identify the drug therapy problem, we put our pharmacist recommendations, and we make it very easy for physicians to they are obviously very busy. If there needs to be a follow-up discussion, then they can certainly call us. And as we get more technology coming online, we know that we're having electronic health records that are being rolled out throughout the country. I can tell you that in New Brunswick we have an EHR that is working right now, and that's certainly going to also help for the documentation. And what I would call, and we're seeing this throughout in Canada kind of showing up, is shared care. So the idea of that is that the best practitioners for their particular scope of practice are working together. They're sharing the care of that patient, which is key to make sure that the outcomes of that patient is where it needs to be. So if you want to move on to the next slide. So this is an example of a very progressive practice of pharmacist practice that's going on in Alberta. So Alberta, probably 4 or 5 years ago now, they've not only expanded the scope of practice in the sense of allowing pharmacists to prescribe for medications or adjust medications to improve chronic conditions, they're actually funding it. So they're funding pharmacists to take the time to sit down with patients, establish care plans. And this was an example of a study that looked at about, I think it was over 700 patients in Alberta to examine their cardiovascular risk. And in particular, looked at, what's the impact of pharmacists who I would say see patients significantly a larger number of times than a lot of practitioners. I think we see each Canadian on average 14 times a year. We are able to assess, do readings, check their blood pressure, and titrate the medication, modify the medication, notify the prescriber, or feed it into the electronic health record. And what we saw was a tremendous reduction. I think it was about 9.37, a reduction in systolic blood pressure versus usual care. And this is an example of pharmacists collaborating, working to get these outcomes down, getting the surrogate outcomes down, and improving the outcomes of the patient. And I really think that pharmacists, part of the problem, of course, is pharmacists embracing this change. And I think if we embrace it, the huge benefit is the collaboration with our partners, obviously a huge impact on the outcomes of the patients, and hopefully a reduction in the downstream costs, the hospitalizations, admissions, and what I would consider, perhaps many medications like the cascading effect that we just saw a great talk on, and being able to reduce that and get those side effects and improve the quality of life of our patients. So I think there's a lot of opportunity here. I think that pharmacists need to really step up and take this by the horns and really start making an impact and collaborating. So Jennifer, that's pretty much my part, and obviously thank you for having me present that today.
Thanks, Alistair. It really was a lot of really interesting information, and you did mention that there's a number of pharmacies similar to yours across Canada now. So I don't know, do you have any sense of how many pharmacies like yours there that do exist across Canada?
I think there's quite a few out west. I think that a lot of the initial recognition that, we need to really utilize pharmacists. So Alberta and BC, you're seeing a lot of that transition. And it is quite a big change. I mean, it's a costly change to reconfigure your practice into this paradigm. But some of the practices may not necessarily have the physical orientation done, but they will still take the time. They will work with what they have, or they'll see the patients at home. So I would say probably that, of all the pharmacies we're seeing, probably, it's hard to put a number on, but I would say there's, at least close to hundreds, if not thousands, out west, because I know that there are some bigger pharmacy groups that have this type of layout, especially in British Columbia. And I think that what you're going to see over time is more funding is being invested in this area, that you're going to see more and more, you're going to see a critical mass of that transition. And what's interesting also, sorry, just to add a quick point, is that we're seeing other jurisdictions. Actually, Australia, for example, Australia has often, in Canada, we often carry our drug program to Australia and New Zealand. What's interesting is actually Australia is liaising with our National Pharmacy Association, CPHA, because they've been receiving over $500 million from the government to expand the scope and improve health outcomes. So they're actually looking to Canada, to Alberta, and British Columbia to be able to implement what we would call advanced pharmacy practice.
Wow, and I'm assuming that work that they're doing is informed by some sort of cost-benefit analysis that shows how cost savings can be achieved really through working with your pharmacist and tapping into the pharmacist more often. I just have another question too about the advanced pharmacy practice form that you had showed on the webinar, and I think that something like that could be available to the participants following this webinar. But I was just curious, do you go ahead and make recommendations on those forms through the consultations you do with the families or the residents? Do you actually go ahead and make those changes without the physician approval, or does the physician actually have to look at it and approve it before the change is actually made?
We can make depending on the province, you can make the change, for increasing a blood pressure medication, for example, from, 12.5 hydrochlorothiazide once a day to 25 milligrams. I mean, 99% of the time we have a conversation with the physician. There's no issues. But there are the idea there is to remove the barriers of titrations or adjustments. And there is some, obviously responsibility and liability that's associated with that. So pharmacists are, if you're going to adjust these things, you need to be doing the appropriate assessment, and you need to do the appropriate documentation and consultation with the family healthcare team. So there is that recognition in a lot of jurisdictions, and it's the data that's coming out of Alberta, and there's been many studies. Actually, we just saw I just saw yesterday a cost analysis on the hypertension one, showing a $12,000 saving per patient per lifetime on the REACH study. So obviously we need to work as a team, and communication is probably the most important thing when you're doing that.
Right. And I was also curious, how often do the physicians actually call your pharmacy and ask about a recommendation that you've put forth? Is it very often or not very often that happens?
I think, maybe Krista can comment about this, but I mean, we do get calls, we're still working the old days here in New Brunswick where we have fax machines and physicians and do phone in prescription orders. We don't have e-prescribing yet, but, we do often have conversations, or we pick up conversations with physicians there and follow up with a consult. I would say that more often we are the ones that are consulting with the physicians, that we're sending out recommendations, or we're making calls, especially if it's a high priority. So I would say it's probably more of us reaching out, and it's understandable. Physicians and other prescribers like nurse practitioners are extremely busy here, certainly in this province and across the country. So it is key to make sure that when you do contact them, you have everything in order. We like to include documentation, though, because that way they can put it on their file, and they do feel more comfortable with that if we are doing changes.
Thanks, Alistair. Krista, do you have anything else to add to that in the context of what Alistair's talked about for the model, the pharmacy model that you work in now? And I'm also curious, Krista, to hear from you, because I know this is a fairly new model that the John Couteau Pharmacy is operating under. Was this same model in place when you were part of the Pan-Canadian Collaborative? And then does this sort of model, in your opinion, kind of make it easier for you to work with care teams to inform things like medication reviews?
So we have just quite recently renovated the store, so we just kind of opened up in May. So when we did the Pan-Canadian, we didn't have this model in place. I think, like, in terms of helping out with the care teams, like when I do it, a lot of times I go right to the nursing home, so I'm not in the pharmacy at that time. But definitely having that model set up, it does kind of leave me with a bit more time where I can, like, if I need to make calls to doctors, if I need to make calls to the nursing home, I do have that time to do it. Now that we are focusing pretty much exclusively on our cognitive duties and don't have to worry as much about the technical duties, which are being done by our assistants and certified technicians. So definitely with this model, I do feel that you have that time available to you to spend more time with the patient when they come in to do a proper review of their medications. And then that, like I said before, that also leaves you with a bit more time to take care of our nursing homes as well.
It's really fascinating. Thanks so much for the information. And we had the question slide up on the screen now, so I will encourage you, we only have a few minutes left for the webinar, but if anybody else has any further questions or comments, please feel free to type them into the chat box and we can answer those questions. As I mentioned, we hope to send you the resource that Alistair shared as part of the materials of this webinar, so you should receive that. Paula, maybe I'll turn it to you for some final reflections. If you have any comments on what Alistair presented or anything else that Krista presented along the way. And then after Paula, then we'll do our few closing remarks and our polling. So Paula?
Well, I think it's really wonderful to see all of the resources that are available from a pharmacy perspective and how people are working together to share care, shall we say, so that collectively you can make a big difference to improving the way prescribing is happening. And I think there's been great gains made in that regards. And this project really just illustrates how that is all coming together. So it's just a great opportunity to put sort of what we know into practice to improve outcomes. So I think it's really wonderful to see.
Thanks, Paula. So I see that someone may be typing a question, but I'm going to go ahead and tell you about some of the upcoming webinars that we have. So on January 27th, we have a webinar that's going to focus on the We Belong International Forum. That's going to showcase some of the experiences, recommendations, and next steps from the Indigenous Youth Forum that CFHI hosted recently. On February 8th, we have the third part in this series, the Transforming Care for the Elderly series. And as I mentioned earlier, if you attend that call, we'll show a little bit more about the results that we've seen in New Brunswick, the appropriate use of antipsychotic collaborative there. And on February 22nd, we have an open call for innovations in palliative care. So it looks like we don't have any other questions there, so I'm going to launch the live polling and say thank you to everybody for attending. So for the live poll, your answers are not shown on the screen, so please just submit your responses and everything is anonymous. Your feedback is invaluable to us. It helps us to design future webinars, so please just take a moment before you sign off to complete the survey. And we do invite you to sign up for our CFHI newsletter and keep an eye on your email for a full list of upcoming webinars. So this does conclude today's webinar. A warm thank you to Krista, Alistair, and Paula for presenting today, and to all the participants on the line. Thanks very much.
This concludes today's call. Thank you for your participation. You may now disconnect.